Hey, welcome everybody to Anxiety Unraveled. I am your host, Mike Maddox. I'm so glad you're spending some of your time with us on this podcast. If you've watched or listened to this podcast in the past, you know that we exist to take the stigma away from anxiety disorders, to get information out there that you're not alone, that there is treatment, and to take it out of the shadows. And we do that by talking to experts and guests who work in the field of anxiety disorder. So I'm really excited to have with me on this episode my guest, David Ross. David is the executive director of Odyssey Behavioral Health, Pasadena Villa in West Michigan. And David, welcome to the program.
Well, thank you for having me. I'm honored to be here and to help have a conversation around OCD and treatment in our local community. So thank you, and I'm proud to be here.
Yeah, it's so good to talk to you. And I know a little bit about the work that you're doing, the amazing work you're doing. So, but for the audience who may not be familiar with Pasadena Villa or Odyssey Behavioral Health, can you give an overview? Like, what do you do there? What's the purpose of the organization? Who do you treat? Who do you see?
Yeah, so at Pasadena, we're fairly new to Michigan. We've only been in Grand Rapids for a little over a year. Pasadena Villa itself has been around for a long time in other states, and we were brought here by Blue Cross Blue Shield to really bridge the gap between our traditional outpatient therapy, which a lot of individuals know about, and then that inpatient level of care. We offer partial hospitalization in Grand Rapids and intensive outpatient, which basically means that we support individuals that have a high level of acuity, from suicide ideations to self-harmful behaviors to OCD and anxiety and depression and PTSD and trauma responses. And so our level of care is really in our continuum of care to provide that bridge between that inpatient level of care and outpatient. And so our PHP program runs 6 hours a day, 5 days a week. It's pretty intense. We offer medication management at our location in Grand Rapids. And our job and role is to really prevent inpatient hospitalization. Our
That's
goal is
a,
to stabilize individuals so they don't have to go there. And our IOP runs 3 hours a day, 5 days a week. We also have an evening IOP for our working individuals to be able to go to work and still get the support that they need. And our EIOP in the evening is great when it's paired with some sort of evidence-based treatment like EMDR or trauma, TFCBT for those individuals who are working through that trauma. And we can help with the IOP in the evening to begin to build some of those basic functions and restore their functioning so they can work in that trauma and
so
doing some of that work with their outpatient
help,
therapists.
help me with the acronyms. What's IOP?
Sure. I'm sorry, intensive outpatient. Yes. In social work, there are a ton of acronyms. So
Yeah.
PHP is partial hospitalization and IOP is intensive outpatient therapy. So
Okay.
it's just we have a lot of support, a lot of individuals that have been in inpatient hospitals and not had great success. Our treatment it really focuses on evidence-based treatment, and it
Mm.
focuses on therapy as its main treatment modality, not medication management. It definitely is a piece to what we do because we know that medication management along with therapy is best practice. We see great results with our individuals that come into our care. We're a little bit different than some of our other counterparts in the community because our PHP and IOP can be from 6 to 8 weeks. So it's a commitment for our individuals, but when they come through our treatment and they are engaged and they are motivated to, even if they're not motivated, we help support that when people are non-motivated as well. But at the end of the day, when people complete our treatment, we often don't see them go into higher levels of care. We're transitioning them back to our outpatient partners, and they're ready to do that long-term work that has to happen in outpatient therapy for those, especially people who are struggling with anxiety, depression, and trauma-related responses, PTSD and OCD as well. It takes a long time for those individuals to find that consistency and support that they need.
That's amazing. That's great work and much needed work and very effective from what you're seeing. So appreciate appreciate that intro and that overview. I want to get into with you this week. I want to talk about OCD. OCD is something that everybody's familiar with the acronym now, obsessive compulsive disorder. But I think there's a lot that's still unknown about OCD, or there's a lot of things that are maybe misunderstood.
Mhm.
So let's talk about that a little bit. So first, can you define, maybe what is often misunderstood about obsessive compulsive disorder in the general public and what they've seen on TV shows or movies or whatever?
Yeah, I think the Hollywood has done a really poor job of portraying what OCD is, and so I think most of us have learned about it through that casual language, right? That stereotypes, that the way the media um, portrays OCD instead of the clinical understanding of it, right? And so, everyday conversations, people say things like, "Oh, I have OCD," but they really mean that they like things organized or clean. It's not true OCD in that way. What makes OCD sound more like a personality trait rather than really a serious condition that can cause significant distress for individuals. And so, when I think about the problem, like with those portrayals, is that it really narrows that the image of what OCD is. People think that hand washing or perfectionism is what OCD is, but it's not. It's that obsessive compulsions that leads to a lot of impaired functioning, a lot of shame and um, fear that comes with OCD. That's really the kind of the misconception, I think, of what it is, and really the
Yeah.
biggest difference is that OCD people can't move unless they do something about it, right? And so it's not about being particular or doing something in a certain way. It's more like I can't move unless I do something about this or if I
Yeah.
act
So
on this.
it's not an idiosyncrasy. It's not a personality trait. It's
Right.
an inhibitor in their life. That's the
Yeah.
line, right? That's the line between I'm a perfectionist, I have some OCD tendencies, and I have obsessive compulsive disorder, which is a
Mhm.
serious mental disorder. So if we break that down a little bit further, though, so obsessive compulsive disorder, the obsessions are the explain that they're the thoughts, right? The getting stuck, like I can't. You said I can't move.
Right.
Um, go into that in a little more detail so people would understand. Like for a person who's got acute OCD, what's an obsession like? What does that feel like?
Sure, obsessions really are those unwanted intrusive thoughts, right? It can be images, it can be urges, it can be doubts or fears that keep showing up and create lots of distress for us. They're not the same, thing as our values, right? In fact, our those obsessions really attack our individual personal values the most, which is why they can be so strong and so distressing. So that obsession is those unwanted thoughts, those intrusive thoughts that we continue to get. And then like the second part of that is the compulsion part of that, right? That's the behavior, the action of doing and following kind of that cycle, what OCD does create within an individual.
Okay, so the unwanted thought would be I believe that I may have left the oven on, and
Hmm.
that thought gets stuck and gets stuck at to such a strong degree that the person can, to use your words, can't move. They're trying to go to work, but they can't leave because they're worried that the oven's on. And
Hmm.
so then the compulsion is the action, right? Go back and check the oven.
Yeah, it's that visual component, right? The compulsions that like you're saying with like going back and checking the stove, right? And then rechecking the stove and we get that relief when we do those things, but that also creates that ritual, right? And so that compulsions are those visual components where it could be hand washing or checking locks or repeatedly asking for reassurance or arranging things in a certain way. You could avoid certain places or things too. Those are really what compulsions are. And I think some of the misconception too is like that's that visual compulsion, right? But there are also things that are not visible to us. And there's more of those mental compulsions, where it's what's happening inside of our head versus what we can actually see out to being to be visible to the public.
And for a person that's in acute struggle with OCD, the obsession comes, the compulsion. You said this, it provides temporary relief, right? I looked at the oven, the oven's not on. You get some temporary relief, but the the danger in that is then that you're forming new neural pathways, right, or strengthening
Yep.
these neural pathways in your
Yep.
brain, so that compulsion is going to be stronger and stronger and stronger. So while you're getting temporary relief, you're feeding the beast, right?
Hmm.
You're making it worse. Um, what role, before we get into treatment of that, or like what can you do if you're a person with that? Because there's a lot of treatment. I want to talk about that today, but
Hmm.
what role is anxiety in that cycle, in that process for that person? Um, how does that feed into it? Because OCD is categorized as an anxiety disorder. So where does
Hmm.
anxiety come in?
Yeah, I mean, those two. So OCD is strongly connected to anxiety because of the obsession that it does create, typically around fear, or doubt or uncertainty. And then the compulsion is that person's attempt to reduce that anxiety, right? And so those intensive, intrusive thoughts are usually not the real problem itself, but it because everyone really has those random thoughts, right? The problem is how OCD responds to those thoughts. And it OCD treats every thought like it's a threat, right? And it must be solved to be prevented, or it must be checked or neutralized and explained. So that creates a lot of anxiety because we're constantly needing that reassurance to make sure that we're either safe or that we're discrediting those doubts, those fears, those thoughts that we have. And so the role that it plays, that they're super connected, and it's mostly through fear and uncertainty and the anxiety that creates.
And that's probably that uncertainty that you're touching on. It's often been called OCD is often been called the doubting disorder, right? Where
Mhm.
and speaking as a person that has OCD or has had OCD my whole life, it resonates with me. You know the oven's not. I know the oven's not.
Yeah.
It's that doubt that that
Mhm.
that 1% or fraction of a percent chance that maybe it is. Maybe I bumped the knob, right?
Mhm.
That's the obsession, right? Um, and resisting it can create anxiety. Feeding into the compulsion over and over creates more obsession, which creates more anxiety. So you feel like you're fighting this monster that's bigger than you. So that makes sense to me that that's where anxiety comes in and why it's categorized that way. Um, Uncertainty, right? Is that what really feeds and makes it so powerful?
Yeah, OCD definitely it's called the dinosaur because it does attack certainty, right? And um OCD keeps asking for certainty over and over and over and over again. And certainty, and the reason why it's so hard to combat against that is because certainty is in our lives, nothing is hardly ever 100% certain, right? So
Yeah.
you're not just fighting the actual urges, you're actually just fighting that certainty in itself is very difficult to get 100%. And so it's really a strong compulsion, a really strong driver to that. And so yeah, I mean the OCD piece, it attacks that certainty because it's the most vulnerable part of what we can never get answers to. And so it's really difficult for individuals to get past that. And that's why it just feeds into that OCD.
What are some of the types of OCD that you've seen show up in your practice or that exist? I know people know about hand washing. I guess that's
Mhm.
contamination OCD.
Yeah.
Technically, we talked about checking the oven. That's checking. What are some of the others? You talked about intrusive thoughts. Give us a feel for how broad OCD
Yeah.
can be.
It's very broad. And I think I mean, we see a lot in at Pasadena Villa and Grand Rapids. We see a lot of individuals that come through our door that have some intrusive harm OCD, which involves fear of harming themselves or even harming others. Um, and these thoughts, are really the opposite of what that person's values are, but that's where that ritual, that OCD comes into play when that cycle begins to happen because they're trying to disprove that they don't want to harm themselves or harm others, but that's that harm OCD is one of the ones we see quite a bit. We also see relationship OCDs, where individuals are involved about doubting a relationship. Is this person the right person for them? Do they love me? Do I love them? Whether, all those things, is a relationship right for me? We see that quite a bit as well. And I think we've been seeing an uptick in some of the sexual intrusive thoughts with OCD as well. So this can be thoughts or images, or fears that can be really disturbing to the individual. And oftentimes takes a while for them to really engage with us to build that relationship because this is something that is very personal to that individual. And so we're seeing more of that as well. And there's a lot of shame that comes with the intrusive thoughts of sexual intrusive thoughts and or self-harmful thoughts. But that's kind of what we're seeing. We also see a lot of the mental OCDs of that rumination quite frequently. Um, we've been seeing we also seen quite a few people have had some OCD um, kind of related to excuse me, related to perfectionism as well.
Yeah.
But it's
So
really a wide array of things, and I think we have a lot of people come into our practice that they just label it as generalized anxiety, but the more we work with them, we can really begin to see the patterns that are being created, and it's nice to be able to give them language around what's actually happening to them. And I think there's a level of support that comes with understanding the language that happens when they can begin to pinpoint the things that they're seeing versus just I'm crazy. And
I
that's
think
what a
it's
lot of times what
I
they
think it's
feel.
so powerful what you're talking about, and what you do, which is to go deep with the individual into what is it that you're actually struggling with, because a lot of the power of OCD, and I'm only speaking from my personal experience,
Mhm.
is if you give it you give it power by refusing to bring it out into the open. So you talked about intrusive thoughts. A person who's struggling with unwanted sexual thoughts, and it can be incredibly frightening because these thoughts can be very disturbing. And you said this at the very top of the podcast. They're not your values. They're in fact they're the opposite of what you value. That's what
Mhm.
makes them so scary to the person. But they don't want to admit that, right? They don't want to.
Right.
It's hard for them to say they're having these thoughts, and the more they fight the thought, the stronger the thought gets, right? So talk about that, because I think everybody, and I think you said this already too, I think every human being has unwanted thoughts. Like, and the other topic I'd like you to touch on is something that was helpful in my recovery process over the decades, is that a thought is just a thought. So I don't have
Correct.
any intrinsic value on its own. It's just a thought. We all have millions of random thoughts all the time, all day long. So
Mhm.
talk about that a bit.
Yeah, I mean, you hit the nail on the head, right? Like, I mean, we talk about this all the time in our practice and trying to give a sense of understanding to our individuals. Like, everyone does have random, strange thoughts. Sometimes they can be quite bizarre, and sometimes they can be like, oh, like, why did I think that, right? They're unwanted thoughts. And I always describe it as the brain's way of producing just noise sometimes because it's bored. And so it's this space that we give ourselves. And so they definitely don't match who we are or what we want. And I would say in most cases, people who don't struggle with OCD just dismiss it and move on. The difference is with people who struggle with OCD, that they attach that thought with meaning. And again, this becomes that uncertainty, right? They have this thought and they think, like, why did I think that? What does that say about me? What does that mean? Is there something wrong with me? Am I really going to act on this? And they begin to question themselves, and then they start to try to find that certainty, which then again just reinforces that cycle. That fear turns that thought that they're having, whether that's just a random intrusive thought, into something that's real and it's a threat to them. It's a threat because it's a person usually against something that's very dear to them, that they feel very passionate about, that attacks them at the core. And so the individual that's struggling with OCD then tries to solve it or neutralize it or to prove that that's not me, that's wrong. We try to get reassurance when that thing happens. And so this is where that loop begins with individuals who struggle with OCD.
And so yeah, the more they fight it, the harder it is, and they fight it because it isn't them, and it's so
Hmm.
they're so opposed to that. Um, so what would you tell a person who's going through that, who's struggling with unwanted thoughts, intrusive thoughts? Um, what would your advice be? I mean, obviously therapy helps, but what are some
Sure.
things that you picked up that help lessen that? I mentioned to you a minute ago that the first time somebody said to me that a thought is just a thought and doesn't have value on its own. And what else would you say to somebody who's struggling?
I I would, usually for me it's really about empathy, but just being with that person. I think sometimes, as a therapist myself, we can kind of get caught in that to fix something, right? And I think sometimes it's just really being with that person and just being like, and just validating what they're going through, right? And yeah, the fact is that these thoughts do scare you, right? It doesn't define you. They are very scary, but it doesn't define you. And again, the thought is just a thought, and it may be intrusive, and that, being able to sit there with them and understand them. And one of the biggest things that I would say to them is like, let's just sit here and not try to spend this whole time providing the thought or proving the thought is wrong, right? Because it is just a thought, but it's just being there with them and helping them understand that we can do this together and that there is, I always say light at the end of the tunnel, right? And we can work through this together. That's the biggest thing I would like to help them. But I think the path is to help them and to teach them not to respond or how to respond differently to that they've been responding, because it is impactful and it oftentimes creates a lot of dysfunction, a lot of distress. And there's so much shame that can come with this because sometimes those thoughts are really scary or they're embarrassing. And so people don't like to talk about it. And so I think really just being there with that person and telling them a thought is just a thought, but then going in a little bit more about, let's teach that path to a different process to begin to improve and reduce the strength that it has.
That's so good. And I want to pick up on that and to have you talk about treatment because you said there's light at the end of the tunnel.
Mhm.
Um, and there is hope, there is help. And I'm living proof. I mean, I mentioned that I struggled with OCD in my life, and there was a time early in my life where OCD ruled my life. It doesn't rule my life today. I'm always going to have OCD. I think I've
Yep.
learned that you don't get rid of it.
Not a
But
cure
it,
for it.
yeah, but there's no cure, but there is life. There
Yes.
is you can live in freedom having OCD, and I do every day. But I learned a set of tools over the years that I use. But what I'd like to ask you is, what are some of the treatments and the tools that people can look into? So if you're listening to us and you're thinking, I have OCD, I either have obsessions about checking, I have obsessions about contamination, I have obsessions about intrusive thoughts or about my health, or whatever it is, and I have compulsions to act on them, and I'm in this vicious cycle, and I remember what that felt like, the weight of that. I used to tell people in support groups that I was in that the weight of that most people don't understand just how heavy that is, how hard that is, how much courage it takes to get up every day. If you're that person, what are some things that you can look toward that are effective as far as treatment goes for OCD?
Yeah, so I'll talk at a couple different layers of like treatment, right? And so I'll talk like at Pasadena Villa and here in Grand Rapids. Oftentimes, like we really support clients who are struggling with that, right? And so it happens to be like our work starts by helping them understand the cycle that they're kind of stuck in, right? And so many clients feel like they're failing at, like I said earlier, like they're crazy. And so part of our treatment is to help them put a lot of language around that. I think our language around mental health and challenges can be very narrow. And so we want to help build language around what's happening, right? And so really about the intrusive thought, the anxiety, the avoidance, the reassurance seeking that happens, those compulsions that can happen, and then that temporarily that those things provide. It's also about helping, clients begin to build insight into that short-term relief can sometimes create long-term suffering, and create a lot more seeking assurance and the things that drive our compulsions and our OCD. So, like at our treatment, we offer a combination of like clinical approaches that supports clients. This may include we do CBT treatment and
And
evidence-based
to
treatment at Pasadena. We also use DBT
define,
skills. Like, I'm
I
sorry.
want to stop you for a second. Just define
Yeah,
CBT if folks
yeah.
don't know
So
the acronym.
yeah, so cognitive, yeah, sorry, cognitive behavioral therapy. We use that as a method of treatment. So really, that's about changing cognition and changing patterns. And so that's thinking about the cycle of OCD. That's one of the key factors that we use to help explore that cycle and break that cycle of
So
OCD.
is cognitive behavioral therapy, how is that different from, and we've used the term on this podcast before, exposure response therapy. And I know a lot of folks, like including myself, have used techniques like, if I feel this compulsion to go back and check and see if the doors are locked, I'm not going to act on or I feel the obsession. I'm not going to act on the compulsion I'm going to give myself 10 minutes. Like I'm going to wait. I'm going to delay.
Mhm.
That's exposing myself to the
Correct.
obsession, avoiding the response. Um, how is CBT? Like, what is different about CBT or cognitive behavioral therapy? How does that work for a person?
Yeah, so the exposure prevention really helps, like it does. It's so you're sitting with it more, right? And so you're providing that space between the intrusive thought and the compulsion. And so OCD is really helping people understand the cycle, identifying the unhelpful thoughts, the patterns that come with that, how to change their response to those intrusive thoughts. It's really most effective when you pair that with an ERP therapist as well to provide that cycle and how to break that cycle, but then also that exposure piece where you're actually learning how to gradually face those thoughts and sit with them for a little bit longer, to begin to provide space between intrusive thought and action to that thought. And so
Okay.
those two combined really work well together.
Yeah. So the CBT, cognitive behavioral therapy, understanding the cognitive aspects of what you're going through, the mental aspects, why they're showing up, how they're showing up with a trained professional, and then
Correct.
exposure response is action. You're doing things that expose you to that anxiety in short, manageable ways that you can then begin to lessen the cycle. Okay, that makes sense to me. What else is available for treatment? Medication. People talk about
Med
medication.
Yeah, medications and SSRIs are good. I would say that, that's something that, you always want to talk with your doctor about because I'm not a medical provider, but there are good medications that can help. But again, like I said earlier too, pairing that medication management with actual treatment is really good. And I think DBT can be helpful as well. So I think
DBT.
that, yeah, oh, sorry, my computer just froze. Hold on, sorry.
It's okay. You said DBT, which is what? Still with me?
Yeah, just my mouse and everything kind of froze.
Oh, it's okay. Yeah, you were talking about how medication, it can be effective. It's been proven to be effective, but of course, talk to your doctor um,
Yeah.
about what might work for you, what might not work for you. While you're thinking about that answer, the comment I've often made over the years in talking to people about my experience with medication for anxiety disorder is it's an important tool. It's been a helpful tool for me, but I never found a medication that was a magic pill. I never found a
Hmm.
medication that you just take this pill and it all goes away. If I did, I would have never done CBT. I would have
Sure.
never done exposure response therapy. I would have never done therapy with a trained professional. I never would have done support groups. Um, I would have never done the other work. So I'm grateful that that medication didn't exist because I learned a whole array of tools that are in my toolbox that when I have OCD symptoms are at my disposal now because I've sharpened those tools over decades, right?
Mhm.
You mentioned DBT. I was asking,
Yeah.
what is DBT?
So it's dialectical behavioral therapy. It was developed by Marshall Linehan. We use it a lot in our practice, and it's four pillars of it. You have mindfulness, distress tolerance, and emotional regulation, and then interpersonal effectiveness. And so when we think about how that can be a really nice beginning part to like experiencing how to manage OCD a little bit better, it 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 begins to help them really understand like all the factors of trying to think how I want to word this, but like,
What goes into it? All the things that are
yeah, I
involved
mean,
in.
how to support like with the really the insight that like the emotional regulation, the distress tolerance, and how that all plays a part to support them to be able to be more grounded and sit with those feelings and thoughts a little bit longer. It really works on supporting like that psychoeducation around those types of treatments and just like how do we sit with distress tolerance a little bit longer to be able to provide that sense of relief to not act on those impulses.
Yeah, that makes sense to me. In education, is not often not talked about as a treatment for OCD, but just little things like knowing that, millions of people have intrusive thoughts. In fact, I would go so far as to say everybody has intrusive thoughts, right? That
Mhm.
you're not isolated, you're not alone, right? That is such a light bulb moment for some people if they're in the acute stages of this disease to know that you're not alone. This isn't just you. This is a well documented. There are millions and millions and millions of people with OCD. Um, if you're, yeah, I've got a question for you. With what you've seen in your practice and with patients you've treated, uh, for family members, right? Because if a family member doesn't have OCD and they have maybe a child or a teenager with OCD, what are some mistakes that often get made? Because I've heard had family members go, we just can't think that way. You gotta stop doing that, right? So,
Yep. No, I think sometimes like being that, individuals don't often expressly open or share about what's going on in their head, right? And what kind of thoughts that they're having. And so loved ones may not always know exactly what's going on, but even if they do, we make mistakes because they care, right? They want to help. They want to stop that compulsion from happening. They want to help support the individual from not feeling so distressed and not being able to do what they want. And so family members typically give that reassurance because they
yeah,
love them and they want to help. But
yeah,
what they're actually doing is reinforcing that that individual needs that reassurance,
yeah,
and they're feeding into that cycle.
yeah. They contribute.
Yeah.
I remember a shift in my own marriage and my own family. Again, going back over 30 years now, but from empathy is good, right? And understanding is
Mhm.
good, and you need that. But you also, it isn't helpful, although it's meant to be helpful. It's not helpful for family members to feed into your obsessions,
Right.
to let you continue to build that cycle of obsessive compulsive behavior. Um, so support, empathy, helping that person identify when they're digging in deeper, is a little bit different than feeding into it, right? There's a time I think where family members can enable,
Yep.
and they don't mean to. They're doing it out of care and love, but
Yep.
it can be enabling. Um, so I think that's important to call out. And if you are a person, so a couple of things I want to get to as we wrap up here. We know it can't be cured. If you have OCD, there's no cure.
Hmm.
But and I said it before, I want to say it again, and you correct me if I'm wrong as the professional. I'm just a layperson on the call here, but I want to say this really clearly. You can live a life free from the pain of OCD,
Yes.
and I know that because I do. That's true, correct?
Yeah, absolutely. Yeah. I mean, I think um, you can definitely experience major improvement and live full, meaningful life, and still have intrusive thoughts or symptoms during times of stress. It happens, right? But it's about learning how to respond to them in a different way that doesn't impact you long term. It doesn't create as much distress. We all have events in our lives that cause us distress, and it can be very powerful. And we all can manage and live those things. And so there is a light at the end of the tunnel, so to speak, again, right? We can continue to live full lives, and we can be very productive members of society and be very successful. Doesn't mean we won't have challenges along the way, but it definitely can look a lot different than what people are currently experiencing.
That's so good. Thank you for that. Now, if you are a person that is struggling and you're listening to this podcast, what would you say, David, is the thing they should do first? Like, what would be the thing, as soon as they're done listening to this podcast, what's the next thing they can do? What's the first step, I guess?
I think the first step is really, either reaching out to somebody who is safe to you, or somebody who's like understands OCD. But I think too, it's asking yourself, like, how harmful is this to me, right? To begin to identify what it is exactly and how this harming this is to you. But I think the first step is to really begin to understand it, but then talk to somebody about it so we can help support and give, again, language around what you're experiencing, right? They can reach out to any mental health professional. And again, if you're looking for treatment, I definitely would look into somebody who has or specializes in ERP therapy. It's the recommended level of support and treatment for individuals who have OCD. And I am a firm believer in always, like, even if someone calls us, like, you can call us to call the Anxiety Resource Center to be able to find professional help in the community. Don't try to do it on your own, because it can be very overwhelming when you go onto Psychology Today and try and find a therapist or try to call you. There's so many therapists in our community, and they're all great, but some of them have different specialties. And so just reaching out to a certified, health center like, Pasadena Villa or the Anxiety Resource Center to allow us to help connect you to those individuals. So that way you can get that connection, because you oftentimes, we see this all the time, and when someone's calling, it's because that's when they're ready for help. And so we want to make sure that we're getting that person connected and getting you connected right away, not giving you a list of resources, but connecting you right away. So that way you can get that support that you need.
That's outstanding. Yeah, I appreciate that. And if you are struggling, do reach out for help. You can. How would folks reach you at Pasadena if they were interested in getting information about your program or about therapists?
Yeah, I
What's the
mean,
best way for them to get a hold of you?
they can call our direct number, and it's 616-207-3818. You can go online and make an inquiry online as well. There's lots of ways to do it. And one of the things that, I find to be like my driving factor to the work that we do and the work that I do, and the reason why I got into social work in general, is I don't want people falling through the cracks. And so even if it's not our level of care, let our team help you. We have people that their job is solely to connect people to community partners. And we have a lot of community partners in Grand Rapids and the surrounding areas, that we refer to. And I just have an individual in our care right now that's getting support and getting connected to an ERP therapist in the community. We want to make sure that the match that you're getting for your needs is the right fit. And so our job is to connect you. Even if it's not with us, we want to make sure that you're getting that support, because it's super helpful and important to make sure that you don't fall through the cracks and you don't have to call on yourself, because it is scary. And it takes a lot of courage to call and to get that help.
That's awesome. And the website, is it pasadenavilla.com?
Yes.
Yeah,
I do believe it is. Yeah.
it
I
is.
mean,
I just looked it up to make
okay.
sure.
I was like, yeah.
PASADENVILLA.com. You can also, and David mentioned this, if you're interested in just finding resources, the Anxiety Resource Center in
Mhm.
West Michigan is available to anyone, anywhere in the world, to be a place where you can find resources, get connected to other people who have anxiety disorders. There are support groups that you can join, virtual. We have presentations on a regular basis where professionals like David and others will come in and speak, or even people that have been down the journey, like myself, will come in and speak on what we've experienced. Lending library. So there is help available. Reach out if you're interested in that to the Anxiety Resource Center, and you can find them at anxietyresourcecenter.org. And so, David, I can't tell you how much I appreciate being on the program and sharing the information, and for the work that you do and the other folks at Pasadena Villa do each and every day, truly making a difference in people's lives. And so thank you for being a guest, and thank you for all that you do.
Yes, thank you very much. I appreciate it. And, this is something that's very, very meaningful to us and to our community. And so, any way we can help and support, I can't express our devotion to our community enough.
Thanks again. And thanks everybody for listening. We will be back next time on Anxiety Unraveled. Have a great day, everybody. And we'll see you on the flip side.